When treating a patient with epilepsy, the first line of care is generally anti-epileptic medication, but a significant portion of patients with epilepsy ultimately don't respond to drug treatments and are left with other more invasive options of therapy, such as surgical resection. However, in the past 20 years, new treatment options based in neurostimulation have emerged and become FDA approved for this subpopulation of patients. My name is Vasiliki Corelli, and I'm an MD-PhD student at the University of Pennsylvania, and today I'll be talking to you about using responsive neurostimulation for drug-resistant epilepsy. So drug-resistant epilepsy is exactly what it sounds like. It happens when seizures don't respond to anti-epileptic drugs, or AEDs, and despite there having been many progressions in the field of treatment for this type of epilepsy, we actually still don't know exactly why it happens. There are several models or hypotheses for the mechanism, which have sort of shaped the direction of treatment investigation, and that includes things such as the pharmacokinetic hypothesis, which proposes that overexpression of drug efflux transporters in peripheral organs actually decreases AED plasma levels, ultimately decreasing the amount available to actually reach the epileptic focus. Another hypothesis is the neuronal network one, which is rooted in the idea that seizure-induced degeneration and remodeling suppresses the brain's seizure control system and restricts AEDs from accessing targets. So as you can imagine, treating a patient with epilepsy is not always a straightforward process. Generally, their initial assessment begins by looking at their past medical history and undergoing tests such as a preliminary MRI and a scalp EEG to assess for electrophysiological and structural brain abnormalities. They will then go on to do a medication trial and see what specific AEDs will work for them. At this point, about 2/3 of the patients will be responsive to meds and be able to control their seizures going forward. However, the other 1/3 of patients will need to continue on to either a route of surgical resection or neuromodulation. The evaluation for these therapies can be more invasive and focus on determining a seizure onset zone, or SOZ, which is typically done through additional imaging and intracranial EEG monitoring in the epilepsy monitoring unit. Now, how the process to ultimately being recommended for treatment with RNS looks like can be seen through a real-world case study. So let's say you have a 54-year-old female with focal, non-lesional, and drug-resistant epilepsy who presents for discussion of surgical options for her seizures. She has had seizures since she was about 30 years old and averages 2 seizures per month, which has decreased from 3 per month after medication adjustments. She underwent several medication trials before undergoing pre-surgical evaluation, as in currently is on 2 anti-epileptic drugs. So as we previously discussed, the first phase of her evaluation included an MRI, which showed no structural abnormalities, and a scalp EEG showing left greater than right intraictal discharge with probable bitemporal seizure onsets. The second phase of her evaluation focused on localizing her seizure onset zone. This included intracranial EEG recordings that captured independent bilateral temporal lobe seizure onsets. Further imaging included a PET scan showing bitemporal hypometabolism that was worse on the right, which can be seen in these 3 starred sections, where you can see the slight decrease in intensity in the areas of the temporal lobe, particularly on the right here as compared to the left. Her fMRI showed left language lateralization, which is important to determine because it tells us where to avoid in order to keep language intact during treatment. So based on these findings, this patient was recommended RNS with 1 right hippocampal and 1 left parahippocampal temporal pole electrode. And why is this the case? Well, based on her imaging and EEG recordings, her seizure onset zone is bilateral, so she's not really a candidate for surgical resection since that's usually reserved for patients that have a single seizure onset zone, such that even if you resect one portion of the brain, the other side can compensate. However, in her case, her seizures have proven to be refractory to medications, and she has seizure onset, which is found to be bitemporal. So the next best step for her would be responsive neurostimulation, since you can target both sides concurrently. So we've identified a patient whose next step of care is RNS implantation. So now let's talk about what exactly this device is going to do for her. In general, RNS detects abnormal brain activity and delivers stimulation to disrupt seizure progression. It's designed as a closed-loop system, which means the device continuously senses neural activity and delivers stimulation only in response to the detection of a particular pattern of brain activity that are known to precede the occurrence of seizures in a particular person. The mechanistic model for RNS assumes that it's most effective when stimulation is delivered as close as possible to the seizure focus and as early as possible after seizure onset. And that's why localizing the seizure focus is so important, to not only inform the lead placement, but to refine the detection algorithms being used in order to optimize sensitivity and specificity for seizures. And this process is specific to each patient. After device implantation, patients are given about a month to recover before the device is actually turned on and begins to monitor and stimulate. Continuous recording allows the RNS system to establish what baseline recordings for a specific patient will look like, as well as when there is a change in signal during their epileptic episodes to determine when to stimulate. The indications for RNS implantation include many of the factors we've already talked about, such as patients with medically intractable focal epilepsy, cases where surgical resection is not a viable option, confirmed seizure onset zones through EEG, fMRI, and PET imaging, and patients requiring neuromodulation due to multiple epileptic foci. And these are all criteria that our case study patient met. During the actual surgery for RNS implantation, there are two different types of leads that can be implanted. There are depth leads that contain 4 electrode contacts and are placed within the brain itself using robotic navigation to place these leads exactly where the seizure onset zone was determined, and cortical strip leads that may also be placed during this procedure. The actual neurostimulator, along with its battery, is placed within the skull, as shown here, and the placement of the leads is then verified using imaging. As is the case with many medical devices and treatments, the factors in determining their success is mainly related to longitudinal safety and efficacy. For RNS, there have been several long-term treatment studies to evaluate these factors. These studies have demonstrated that RNS provides significant seizure reduction overall, meaningful seizure-free periods, and consistent quality of life improvements, while also maintaining safety through no chronic stimulation side effects and minimal related medical risks, such as infection or hemorrhage. And while RNS has shown significant efficacy in seizure management, there are still some limitations and uncertainties. While RNS is designed to terminate seizures through acute electrical stimulation, there are several factors that influence how effective it ultimately is. And there's actually limited evidence that supports early stimulation at the seizure focus as a highly effective intervention. And this raises questions about whether RNS should be used as a proactive or reactive therapy. Additionally, brain networks play a significant role in determining how effective RNS therapy will be. Some brain networks are more susceptible to RNS therapy, meaning the pre-implantation evaluation can help identify the best candidates for therapy. And understanding network activity and susceptibility can improve treatment outcomes. The effectiveness of RNS also depends on stimulating key network nodes, which may not actually always overlap with the seizure onset zones, which, as we talked about, are a key factor in determining lead placements. This means that even if leads are placed at the seizure focus, they may not always be targeting the most crucial areas for controlling seizures. Another aspect in the effectiveness of RNS is that it varies depending on the brain's current state. Since seizure likelihood fluctuates over time, and RNS might be more effective during certain network states than others, it raises the questions about whether RNS should be adaptive or personalized to different brain states. And lastly, chronic RNS therapy induces neuromodulatory effects, meaning it doesn't just stop seizures, it actually changes the brain's networks over time. Long-term seizure reduction may depend more on how the brain adapts to stimulation rather than just stopping individual seizures. And although some of these points may seem very uncertain, ultimately there are a lot of therapies and devices in medicine that we know work to a certain extent, but don't completely understand why. But there's a lot of research currently being done to optimize factors such as where to place leads and which networks to target directly, and why, which only serve to improve the capabilities of RNS going forward. These are the references for the papers used in this talk, and thank you so much for your time and listening.